Hello everybody. Today we are going to discuss about the management of the potential organ donation ISCCM guidelines. So this is the pathophysiological event occurring during the severe brain injury. It will cause the rise in the ICP, and then there will be the body's attempt to maintain uh, the cerebral blood flow and cerebral perfusion pressure. Then, because of the increased ICP, there will be the ischemia spread from the rostrocaudal, from cerebellum to the spinal cord. When there will be the ischemic changes in the pons, then it will result into the hypertension and bradycardia. The Cushing response mixed with the sympathetic and the vagal stimulation. If ischemic changes are proceeding towards the medulla, then there will be the rise in the systemic vascular resistance, tachycardia, and arrhythmia. Distal to medulla oblongata, the vagal nucleus become ischemic, and it result into the catecholaminergic storm. Then, when it will proceed to the spinal level, then it will result into the vasoplasia and hypotension. So when treatment that should be directed towards the recovery of the injured brain, and when there will be the hypertension, and when the ischemic events are progressing from rostral to caudal direction involving pons medulla, at that time proper cardiopulmonary metabolic resuscitation should be done to to prevent the organ and the appropriate resuscitation of potentially transplantable solid organ. Then this is the schematic representation of effect into the different organs. So brain death is the catastrophic event that do not only affect the central nervous system but also causes the significant changes in all organs. Changes occurring into the distant organ may attribute to the following cause, like diffuse vascular regulation injury. This is due to massive sympathetic outflow and increase in circulating catecholamines, followed by the reduction into the sympathetic outflow. Then diffuse cellular metabolic injury. This is due to shift in anaerobic metabolism. So common physiological changes in the brainstem death patient, like hypothermia, it is occurring into the 100% of patient. It occurs because of the hypothalamic dysfunction, vasoplasia, weight loss, and reduced metabolic rate. Then there will be the hypotension. It occurs because of myocardial dysfunction, vasoplasia, and hypovolemia. It occurs in 81 to 97% of patients. Then there will be the diabetes insipidus, which results from the posterior pituitary damage. It occurs in 46 to 78% of patients. Then arrhythmia, it occurs because of the catecholamine release in 25 to 32% of patients. Then there will be the pulmonary edema, which occurs because of the endothelial injury and blood volume diversion. Then there will be the DIC, which occurs because of the tissue factor release and coagulopathy. Primary target for maintenance of potential organ donor, mean arterial pressure should be more than 60 to 65. Then heart rate should be 60 to 120. CVP should be 6 to 10. Urine output should be more than 0.5 to 2 ml per kg per hour. PaO2 and pH, that is PF ratio for lung donor, is more than 70 to 100. pH should be more than 7.35 to 7.45. Blood sugar should be in the range of 120 to 180. Hemoglobin should be more than 7. Target temperature range should be between 36.5 to 37.5. Sodium should be more than 135 and less than 155. Potassium should be more than 4 and less than 5. LV ejection fraction should be more than 45%. Cardiac index is equal to 2.4. PaCO2 is 34 to 44. Then ISCCM recommends a list of general measures to be followed during management of the organ donor. The general measures to be followed are listed as follow. That is hand hygiene as per standard medical and nursing care. Propped up positioning to 30 to 35 degrees Celsius. Then eye care, taping of the eyelid to prevent the corneal ulcer and facilitate corneal transplant. The nasogastric tube must be inserted for gastric decompression and prevention of aspiration. Then stress ulcer prophylaxis. Prophylaxis of deep vein thrombosis, pneumatic compression device. Arterial or central venous line should be inserted preferably into upper extremities because the femoral line reading can become inaccurate during surgical procedure for organ procurement. Then frequent change of position for decupitous ulcer prophylaxis, skin care and dressing changes. Then bronchial toilet improves the elimination of secretions and therefore improves the chance of lung donation. Urinary and intravascular catheter must be handled with appropriate care to minimize the risk of infection. Warming blanket to maintain body temperature around 36.5 degree. Broad spectrum antibiotics and document patient's height and weight. So ISCCM recommends close monitoring of the hemodynamic and ventilation parameter. This is for ensuring adequate oxygen and normocapnia. Bedside echocardiography will guide for fluid resuscitation. Real-time cardiac output may be required in case of advanced monitoring. Monitoring is crucial part of medical management. Routine monitoring include ECG, BP, pulse oximetry, core temperature, hourly urine output, and central venous pressure. Repeat bedside echocardiography. Pulse pressure variation is the method that has been used to determine optimal fluid status. Urine output is 1 to 3 ml per kg per hour. Then cardiac index should be above 2.5 and central venous oxygen saturation should be above 70%. Then ISCCM recommended monitoring metabolic parameter every 2 to 4 hours. For example, ABG, lactate, electrolyte, blood sugar level. It recommended sending the blood, urine, and endotracheal secretion for culture from disease organ. Then ISCCM also recommends the adequate time should be given for organ optimization and brain dead donor to come out of the autonomic storm injury. So organ procurement should be done within the 30 hours. For lung and heart procurement time as long as possible. And for kidney, the procurement time should be 20 to 50 hours. Then objectives in the management of the organ donor can be broadly divided further as mentioned. Management of hemodynamics, management of metabolic derangement, management of respiratory application of lung protective low stage ventilation, then temperature management, management of hematological derangement, hematologic parameters, nutrition management, and management of hormonal and metabolic derangement. So this is the main objective, that is the application of lung protective low stage ventilation, correction of hypovolemia, commencement of vasopressin, weaning of catecholamine infusion, prompt diagnosis and management of diabetes insipidus, and attenuate effect of inflammatory response, then infection control, nutrition, hematological, temperature management, and metabolic derangement. ICCM recommended the aggressive management of hemodynamic status of the donor. It recommended maintaining normovolemia, mean arterial pressure, and optimizing cardiac output. The recommended mean arterial pressure is from the 60 to 65 mmHg. Hemodynamic instability and cardiac dysfunction are always encountered. Myocardial and hemodynamic changes are seen when intracranial pressure increases above mean arterial pressure and body tries to maintain cerebral blood flow and cerebral perfusion pressure. Ischemia spreads from the rostrocaudally from cerebrum to spinal cord. Pontine ischemia is seen clinically as Cushing response. that is mixed sympathetic and vagal stimulation leads to hypertension and bradycardia. As ischemia progresses towards the distal medulla oblongata, making vagal motor ischemic leads to catecholamine storm, which leads to intense vasoconstriction and tachycardia. This results in myocardial and visceral ischemia, including myocardial and conduction system necrosis. As ischemia progresses to spinal cord, there is loss of function of thoracic sympathetic chain and loss of vascular tone, leading to vasoplasia, hypotension, and vasodilation. As aortic diastolic pressure decreases, this compromises coronary blood flow. Another cause of reduction in the coronary blood flow is endothelial dysfunction. Other causes of hypotension is use of mannitol, hyperglycemia-induced osmotic diuresis, diabetic insipidus, cold diuresis, inadequate fluid resuscitation, ongoing blood loss due to trauma. Then it is recommended that the use of hypertensive should be avoided. Due to transient nature of autonomic storm, antihypertensives are usually not required. If needed, short-acting antihypertensives such as ismolol, sodium nitroprusside, hydrolazine, labetalol, and nitroglycerin should be used. Then antihypertensive is not required for long time. Then it is recommended to aggressively treat the hypotension. It is three recommended measures to keep donor hemodynamically stable are volume expansion, vasopressor, inotropes, and hormone replacement. ISCCM recommends the use of isotonic crystalloid with balanced salt solution. It is recommended to avoid colloid, and it is recommended to transfuse PRBC to maintain hematocrit of more than 30%. ISCCM recommends the use of vasopressor to maintain MAP of more than 60 to 65 mmHg, SBP of more than 100 mmHg after and during fluid resuscitation is done. The choice of vasopressor depends on the presence of diabetes insipidus and organ-specific requirement. ISCCM also recommended the hormonal replacement therapy with T4 and methylprednisolone can be considered in hemodynamically unstable patients who are adequately fluid resuscitated and are on vasopressor support. Hypovolemia is present in brain death patient and it should be addressed primarily before proceeding for further intervention. Simultaneously look for the other cause of hypotension. Initial approach is to replenish the circulating volume. The fluid of choice to avoid hypernatremia and hyperchloremic metabolic acidosis, 0.9% normal saline should be avoided. Dextrose should be avoided to prevent hyperglycemia and hypothermia. Colloid hydroxyethyl starch should be avoided in organ donor due to risk of renal injury. Albumin can be used, but sodium level need to be monitored. The most commonly used fluids are half normal saline, ringer lactate, and plasmolite. PRBC should be transfused to achieve hematocrit of more than or equal to 30% to maintain oxygen delivery. Vasopressin up to 2.4 may reduce the requirement of other inotrope. Norepinephrine is also used to maintain MAP. Due to autonomic storm, few donor may develop stress cardiomyopathy and failing heart can be supported with the dobutamine. Anterior pituitary, regarding hormonal replacement, anterior pituitary function is well preserved in most donors with normal value of TSH, ACTH, and the human growth hormone. Thyroid hormone and TSH are typical for sick euthyroid syndrome that often accompanies severe brain injury rather than the result of TSH deficiency. Posterior pituitary function is lost in 80% of brain dead patients. So central diabetes insipidus result from the deficiency of antidiuretic hormone, which is characterized by polyuria, hyperosmolarity, and the hypernatremia. So hormonal treatment is initiated in donor in whom volume resuscitation and vasopressor have failed to achieve the hemodynamic stability. T3 administration is not easily available in India. Thyroxine, that is T4, 300 to 400 microgram, can be given through nasogastric tube in hemodynamically unstable patient, but absorption and clinical effects are not proven. Methylprednisolone 15 mg per kg immediately after diagnosis of brain death and every 24 hours. Then VP approach, that is ventilation, infusion, and pharmacological support approach. It is simplified and systemic approach to guide hemodynamic management. So this is the flow diagram of VP approach. That is the ventilation. It is the low stretch protocol. That is PaCO2 should be between 35 to 45. PO2 should be more than 100. pH should be in the range of 7.35 to 7.45. Saturation should be more than 95%. Use recruitment manual if needed, prone, and use ECMO. Then regarding hemodynamics instability, first correct hypovolemia by infusing aggressive fluid resuscitation. Pulse pressure variation should be more than 50. Fluid resuscitation to replenish normal circulating volume. If there is diabetes insipidus, then use vasopressin or desmopressin. MAP should be more than 65 mmHg. Urinary output should be more than 0.5 to 1 ml per kg. Then in case of cardiac function, if for LV dysfunction, temperature more than 35, adequate fluid should be given, taper vasopressor, consider dobutamine and ECMO if needed. Then regarding vasodilatation, if pulse pressure variation is less than 50, start vasoconstrictor, vasopressin in the dose of 0.5 to 2.4, noradrenaline, and consider the HRT. That is hormonal replacement therapy. Then ISCCM recommends that arrhythmia in organ donor should be detected, prevented, and treated immediately. It is also recommended to aggressively correct sodium. It is recommended to maintain the blood sugar between 80 to 150 and sodium level should be maintained below 160. ISCCM recommends the lung protective ventilation protocol using low tidal volume, plateau pressure below 30, minimum oxygen requirement, and PEEP of 5 or high as necessarily adjusted to maintain PaO2 above 70. Then it is also recommended to prevent hypothermia in potential organ donor and maintain the temperature between 35 and 36. It is recommended to give PRBC transfusion if HCT is below 30% and a continuation of low molecular weight heparin in patient with normal coagulation and platelet. It is recommended continuing enteral nutrition in the management of potential of organ donor. Then it is recommended to give hormonal replacement therapy in maintenance of potential organ donor. Vasopressin 1 unit bolus followed by infusion of 0.5 to 0.04 unit per minute. Then methylprednisolone 15 mg per kg immediately after diagnosis of brain death, 24 hours thereafter, or another option is 250 mg followed by 100 mg per hour till organ retrieval. Insulin infusion to maintain the blood glucose level between 80 to 150. T4 in the dose of 20 microgram bolus followed by infusion of 10 microgram per hour. T3 given as 4 microgram bolus followed by infusion of 3 microgram per hour. T4 improves hemodynamics, prevent cardiovascular collapse in a hemodynamically unstable organ donor. However, intravenous T3 generally not available. So T4 oral 300 to 400 microgram every 8 hourly suggested instead of T3. In hemodynamically stable patient, desmopressin dose in the dose of 1 to 4 microgram followed by 1 to 2 microgram every 6 hour monitoring the sodium and urine output. If a donor is hemodynamically unstable, then use the vasopressin bolus followed by the 1 unit bolus followed by infusion of 0.5 to 4 unit per hour. Then it is recommended to adopt the appropriate infection control measure to prevent the infection in the donor. Then it is also recommended that bacteremia and sepsis are not contraindicated to donation, provided the pathogen-specific antibiotic have been administered for at least 48 hours prior to procurement and the recipient receives pathogen-specific antibiotic for 7 to 10 days. Positive blood culture in the potential donor are not unusual and documented rate is 20% in the literature. The incidence of positive blood culture appear to be higher in older donor and in donor whose length of stay is more than 3 days. In younger donor, the bacteremia is likely due to gram-positive organism, and in older, it is due to gram-negative. However, rate of transmission of infection to the recipient is less, provided donor organ procurement is delayed for 48 hours, so that donor receives antibiotic as per culture sensitivity for 48 hours. If blood culture of donor comes positive after organ transplantation, this should be communicated with transplant intensivist transplant surgeon so that recipient will receive the pathogen specific antibiotic for 7 to 10 days. So can this potential brain donor with meningitis donate the organ? So the potential organ donor with bacterial meningitis are considered suitable for organ procurement only if they receive pathogen-specific antibiotic or therapy against the probable pathogen. The suggested duration of therapy is same as above. The recipient should receive the similar antibiotic for 5 to 10 days. Furthermore, uh, uh, this potential branded donor with undiagnosed febrile illness, encephalitis, meningitis, flaccid paralysis of unknown cause, and lymphocytic choriomeningitis virus, rabies are absolute contraindication for organ donation. It is recommended that the cases of refusal of organ donation need to be recorded and measure to take overcome the hurdles should be taken. Thank you guys.